the transition from acute to chronic pain, right? Although a lot of people have chronic pain, they can't remember any acute episode. So that's fibromyalgia is usually like that. They can't remember when it started.
Right.
But a lot of chronic pain, they know when it started. And we know too that if that acute pain is not treated properly with, painkillers or anti-inflammatories or ice, if you let the person suffers a lot in acute pain, that is also a good factor to break the pain system, to cause that deregulation of the pain. So we need to be careful when we say, don't, let's throw all the pain pills, the painkillers. And no, that's not true, because we need them to block the acute pain, so then the pain system doesn't get sensitized and will not develop chronic pain. What I'm talking about that the painkillers rarely help is when this acute pain has already healed, there's no more evidence of acute pain, and all that we see is a nociplastic pain, which is the pain system is malfunctioning. In this case, the painkillers really don't do a lot, and actually they can make the pain worse. So the trick for us is to find out when are we not treating the acute pain anymore, and now we are treating the chronic. So once a pain transforms from acute to nociplastic, if you give opioids, there is evidence, there's a lot of scientific evidence for this, what I'm going to tell you. The opioid will activate some receptors that were not meant for the opioids, they were meant for glutamate. And those receptors will be activated, and now the opioid will cause more pain. It's called opioid-induced hyperalgesia. So if the person has nociplastic pain and they start taking opioids, initially they will feel some pain relief, because they will initially feel good, they will feel well, and then they will start taking this around the clock, every 8 hours, every 12 hours, every 6 hours. Their body will become dependent, which means that they need a higher dose to have the same effect, and they will feel good. They will say, doctor, don't modify anything. I'm feeling good on this medication. I'm not addicted. I'm not abusing this medication. I'm taking as prescribed, and I feel okay. But what I tell them is, but look, what if this medication now is perpetuating your chronic pain? And every time that you stop a pill, let's say you miss a dose, or you skip a dose, you feel so horrible that actually you are treating the withdrawals from that medication. Actually, when you skip a dose and you feel pain all over your body, that's not your original pain, that's withdrawals. So you're taking the opioid just to maintain your body without withdrawals. Now this opioid is perpetuating the mechanism of your pain, and you are in a vicious cycle. So that's when I explain to them, let's try to taper. We'll try to taper. I usually do a very slow taper. I never do forced taper. The patient has to be on board with me. And as we start tapering the dose slowly, they may have some withdrawals. Therefore, sometimes we need to treat their withdrawals or switch them to something else called buprenorphine. But then they start feeling more awake. They notice that their bowels are working better, that their sleep is better, that they are they are not so sleepy during the day, they are more alert. And then we continue tapering the dose, and sometimes we have to pause. We don't go all the way to zero, but sometimes we go to zero, and I hear this, well, I don't know why I was taking all of that medication, because I still have my pain, the pain is the same, or the pain is better. And I was having all of those side effects. I'm so glad that I'm not taking them anymore. So I hear this all the time with people that have especially nociplastic pain. At the same time that we are lowering the dose of the opioid, we have to invest in other strategies like the 5 M's, right? We invest on movement, mind-body therapies, self-massage, modalities, like they start using a TENS machine. Actually, a TENS machine, what it does, you put in your skin, but it goes to the brain and it stimulates your brain to produce your own endogenous opioids, like endorphins. So what happens is a lot of people who had been on opioids for so long, their brain is almost like unable to produce their own endogenous opioids. kind of they abolished completely. And it's so hard for me to go in the last steps of tapering. Sometimes it's really hard because their own endogenous opioids they can't produce. So a lot of people will have to stay on opioids for the rest of their life, but on a tiny dose, just because their brain cannot produce their own. Or they start using other methods to stimulate their brain. One of them is dance. Another one is exercise. You probably heard about a runner's high. People who run, and they get high. That's because when they do exercise, they stimulate their brain to produce endorphins. So we use that in our patients, saying, okay, if you start moving, your body will send impulses to your brain to produce your own endogenous opioids, and then you will not need to be taking those pills. So we work, those things, they complement each other a lot. And then that's how we are able to do some successful tapers.